Okay. Good afternoon, everyone. This is Alyssa Williams, Director in the Cancer Health Service Line, and I wanted to welcome you to Day 5 of our Spectrum Health Oncology Symposium. We are very excited to have some excellent speakers today. And before we get started, I would just like to bring up a few housekeeping items. First of all, the session will be recorded, and anyone claiming CME credit, please complete the sign-in process through the Cloud CME mobile app. The number to text will be listed on the next screen here, 31804, or you can use the single sign-on option. Please mute your microphone if you haven't yet. Turn your video off. I don't see anybody yet with their video on. And then to pin the guest presenters, Dr. Abdallah and Dr. Franey for this first hour, right-click on their name and select the pin option. All right. I will go ahead and introduce both speakers. Dr. Abdallah and Dr. Franey are going to kind of take turns in their presentations, but I'll introduce both right now. Dr. Wissam Abdallah is a board-certified cardiologist and a fellow of the American College of Cardiology. Dr. Abdallah earned his medical degree from the George Washington University School of Medicine in Washington, D.C., and completed his internal medicine residency at University of Michigan Hospitals in Ann Arbor. He completed fellowships in cardiovascular medicine and advanced imaging and cardiac MRI at Vanderbilt University Medical Center in Nashville, Tennessee. Dr. Abdallah's clinical interests include advanced cardiac imaging, cardio-oncology, valvular heart disease, and various cardiomyopathies. Welcome, Dr. Abdallah. Dr. Laura Franey is a cardiologist specializing in advanced cardiovascular imaging. Dr. Franey earned her medical degree from Stritch School of Medicine at Loyola University, Chicago. She completed her internal medicine residency, her cardiovascular disease fellowship, and her advanced cardiovascular imaging fellowship at William Beaumont Hospital in Royal Oak. Dr. Franey's clinical interests include cardiovascular magnetic resonance imaging, coronary computed tomography, angiography, sorry, you're really testing my medical knowledge here, and adult echocardiography, and valvular and structural heart disease. Whew, that's a mouthful. I'm very pleased to introduce both of them. They have been critical in our management of patients, and we really look forward to what they have to say today. So thank you, Dr. Abdallah and Dr. Franey, for joining us, and I will turn it over to Dr. Abdallah.
Thank you very much, and thanks for having us. I'm going to share my screen here. And thank you for giving us the opportunity to talk to you about our cardio-oncology program, really focusing on the cardiac care of cancer patients. Now, cardio-oncology is really a new field. It's a multidisciplinary field by definition, focusing on both heart disease in cancer patients. Now, the mission we think of this program is to prevent today's cancer patients from becoming tomorrow's heart patients. And we do serve as experts in the field of cardio-oncology with regards to the various cardiac side effects a very rapidly growing list of cancer therapeutics may have on the cardiovascular system. We do work very closely, whether with the oncology, our oncology colleagues, primary care, surgical oncology, or radiation therapy in terms of optimizing the cardiac care and treating cardiac complications from any potential side effects. Now, the goals of our program, we think of it as threefold. Number one is prevention. So we'd like to focus on optimizing the cardiovascular risk factors for cancer patients. And there is more and more data now showing us that if we optimize patients' cardiovascular risk profile, we can potentially reduce the likelihood for cardiac side effects from their cancer treatment. During the treatment phase, there is now guidelines with regards to frequency of imaging and when to identify early signs of cardiotoxicity. And certainly we would treat this toxicity and always with the goal to avoid interrupting cancer treatment. And then also long-term surveillance, so really focusing on the cancer survivors, those who do not necessarily have any cardiac symptoms, but because of the cancer treatment they have received, they would be at a higher risk for potential cardiac complications down the road, which could be several years down the road, even after their cancer treatment. And there are also guidelines with regards to the frequency of imaging to detect early toxicities as well, which I'll also highlight. Now, one of the reasons there is even a field of cardio-oncology is because of the excellent work our oncology colleagues are doing, where cancer survivorship has significantly improved over the years. So currently there's about 17 million cancer survivors, and that's projected to go up to over 26 million cancer survivors by the year 2040. So cancer patients are living longer, and as a consequence, we are seeing potentially long-term potential side effects from their cancer treatment that they would have received many years ago when potentially life expectancy was less, but now we are seeing these side effects. Now, there's a lot of overlap between cardiovascular disease and cancer. The predisposition to develop cancer and heart disease includes things like advanced age, some predisposition to gender, some and various other risk factors. So tobacco abuse, diabetes, hypertension, hyperlipidemia, sedentary lifestyle, lack of exercise and environmental exposures. A lot of these oxidative stress effects that could affect the body, increase the likelihood for both heart disease as well as cancer. So it's kind of this double hit hypothesis where patients develop a form of cancer, and then the type of treatment they are receiving, if they have already what we could consider like a low cardiac reserve, then that kind of tips them over, and these patients would be at a higher risk for cardiotoxicity and various other cardiac side effects. So a lot of overlap in terms of the risk factors for both cancer and heart disease that serves as a link between these two conditions. In terms of the cancer treatment, and this can be a 1-hour lecture by itself to highlight the various cancer agents and their effect on the cardiovascular system. Historically, we've all learned about the anthracycline-based chemotherapy and the risk of cardiotoxicity, but that is really a small number of agents that have cardiac side effects. Even a lot of the newer targeted therapies have various cardiovascular side effects. One big class are the VEGF inhibitors that are used for various kinds of cancers that have a significant incidence of causing hypertension, valvular heart disease in, for example, patients who've had prior radiation exposure, especially when chest radiation was more extensive and far less shielding than current techniques. So it's really now that we're seeing the 40 and the 50-year-olds who were radiated 20, 30 years ago when they were in their teens, and now they have premature valvular disease, premature coronary artery disease. Various arrhythmias from a lot of different agents have also been implicated. One of the agents that has been utilized and with great success in CLL patients, for example, is Imbruvica or ibrutinib, and that has about a 10% incidence of causing atrial fibrillation, among other arrhythmias. And then so really a very large lot of various cancer agents with various potential cardiac complications. With these immune checkpoint inhibitors, there has been association with cardiomyopathies, but also we've learned about occasional instances of immune checkpoint inhibitors causing myocarditis as well. So a lot of interplay between these agents, whether they're the older agents like anthracycline-based chemotherapy or newer agents that are supposed to be targeted but also seem to have various cardiovascular side effects. And I want to highlight a few papers just kind of trying to show the magnitude of this problem. Fortunately, it's not very common, but again, at the same time, it's not very rare. So this is data from about over 1,600 breast cancer patients, and they looked at their cardiovascular profile and their risk factors and their age and the type of chemotherapy that they were being exposed to. And they developed a scoring system. So if they received any form of chemotherapy, they would get a couple of points, and depending on how old they are, they also got a point assignment for that. And then depending on what kind of cardiac, if they have coronary artery disease or if they have risk factors for coronary artery disease, they also get points for this. And so they were able to show in the derivation model, and then when they validated it in the validation arm here as well, that the patients should, let's say someone has 4 points. So if we go back to this, if someone's receiving chemotherapy, that automatically gives them 2 points. And then let's say they also have renal failure, or they also have diabetes and hypertension, which is probably at least half of the cancer patients have diabetes and hypertension and then cancer. So that automatically puts these patients at a medium risk for potential heart failure and cardiomyopathy. So we're talking over a 3-year period, these patients that have 4 to 5 points on this particular scaling scale have about a 25% incidence of heart failure or cardiomyopathy, and then certainly higher in those who even have more risk factors. So this is not a small patient population, and definitely identifying these patients early on, screening them, closely following them can have a big impact in terms of their long-term outcome as well. This is another paper also looking at breast cancer patients. This was about 1,500 breast cancer patients where they also evaluated their cardiac risk factors or if they had coronary artery disease, and following these patients out to 7 years, those who had diabetes, hypertension, or known coronary artery disease had a significant risk of cardiac events, and that includes acute coronary syndrome as well as heart failure. So we're talking within 7 years, those patients with diabetes or hypertension or coronary disease have a 30 to 40% incidence of a cardiovascular event. This is showing you the number of cardiac risk factors. So the more risk factors, the higher is the incidence of potential cardiac events. So really not a small patient population at all. This paper looked at 748 lung cancer patients who received radiation therapy. And they classified those as receiving radiation therapy as either having pre-existing heart disease or none. Those who had no pre-existing heart disease had a very low incidence of cardiac events versus up to 20% incidence of cardiac events in those who had pre-existing heart disease and received radiation therapy. Interestingly, there was no difference with regards to whether they received a low or a high dose. So this is in the patients who had no pre-existing heart disease. If they had low or high dose radiation exposure to the heart area, the cardiac events was still pretty low. But then if they had coronary artery disease and then they got either low or high radiation, they still had a comparable and significant incidence of cardiac events. Now, I want to highlight also the stages of heart failure. The stages of heart failure, which what we call, they go from A to D. So stage A are those who are at high risk for heart failure, but do not have structural heart disease or symptoms of heart failure. Which patients qualify into this category are those who have hypertension, atherosclerotic disease, diabetes, obesity, but also those who are being exposed to cardiotoxins. So cancer patients that are receiving potentially cardiotoxic agents are automatically in a stage A heart failure category. And the recommendation is to be very aggressive upfront in terms of risk factor modification. Stage B are those who have structural heart disease but don't have any symptoms of heart failure. And in those patients, we are certainly far more aggressive in managing their cardiovascular health. And patients that would potentially fall into the stage B category are those that we might identify some early signs on their echoes, for example, that show some structural heart disease, but they have not manifested in any heart failure, to prevent them, to manage them and optimize them, to prevent them from going down this pathway to more advanced stages of heart failure. So identifying these patients early on and optimizing their cardiovascular risk profile can have an impact on their long-term outcomes as well. Now, with regards to the definition of cardiotoxicity, different trials are going to utilize different definitions for this. The one that we utilize and adapt is the one from the American Society of Echo, where the definition of cancer therapeutics related cardiac dysfunction is defined as those who have a decline in their LVEF by more than 10 points to a value which drops less than 53%. Meaning, let's say they start off with an echo of 69%, ejection fraction was 69%. On the repeat study, it was 56%. So that is more than 10 points, but it's still over 53. So we would not consider that technically a cardiomyopathy, because there is variability from study to study in terms of how the technique is done. And then also importantly, we must confirm that this is a real decline, and to repeat imaging shortly thereafter to indeed show that this is actually a real change before we go down the pathway of talking about interrupting treatment for any form of cancer. And then we also utilize advanced imaging techniques in echo called strain. And strain is a marker of toxicity or cardiomyopathy before the ejection fraction drops. And this is a funny number in that the more negative it is, the better it is. And what I mean by that is we are measuring longitudinal strain. So if you have a muscle fiber, let's say it's 2 centimeters in length, the heart muscle contracts, it's going to shrink in the longitudinal direction. And if it goes down from 2 centimeters to 1.6 centimeters, so that's a minus 20% reduction, that's good. So the more negative, the better that number is, because if it doesn't contract as well, it will only, let's say, change minus 10%. So that's bad. As it gets closer to 0, that's abnormal. And normally the strain will become abnormal about 3 to 6 months before the ejection fraction drops. So we use this, we monitor this closely as a sign of early toxicity. And this is just an example where we're able to track the myocardium, and the program will allow us to track these speckles and give us a strain value. And then sometimes we'll also utilize cardiac MRI to evaluate for any potential cardiotoxicity, especially in patients where we might have poor image quality on an echocardiogram, and we want to have an accurate assessment before we make any recommendations with regards to interrupting or holding on treatment. So we want to have the best information possible, and cardiac MRI, the heart gives us pristine images of heart function that would allow us to far more confidently exclude a cardiomyopathy. Also, other techniques allow us to look for fibrosis. So if patients have had occult infarcts, we've had patients who've had chest pain symptoms while on 5-FU, for example, and we've identified occult infarcts. This would also be the technique to evaluate for myocarditis, for example, if there's a concern. Patients are on immune checkpoint inhibitors. This would be the imaging modality to utilize to evaluate for myocarditis. And then also looking for infiltrative cardiomyopathies, for example, such as amyloid in, let's say, multiple myeloma patients, and they have some left ventricular hypertrophy on their echo. We have identified a fair number of cardiac amyloid as well, and cardiac MRI is the imaging modality of choice for that. Now, there are some guidelines with regards to screening, and I just want to highlight a few. Again, it's a new field, so not a lot out there, but the American Heart Association does have guidelines in terms of the frequency of imaging for anthracycline-based imaging, anthracycline-based chemotherapy, or HER2 blocking agents. All these patients get baseline echocardiograms if they're getting HER2 blocking agents every 3 months. Anthracycline chemotherapy, depending on the cumulative dose, frequency of imaging might change, but then also at the completion, and then normally we'll also do another echo 6 months afterwards. The American Society of Clinical Oncology also released this very nice document in 2017, recognizing which patients would be at higher risk for cardiac dysfunction. So they identify those with high risk with high dose anthracycline therapy or radiotherapy, or those with lower doses, but also have multiple cardiovascular risk factors, 2 or more risk factors. And then they also talk a little bit about screening, evaluating these patients clinically, following them long-term, echocardiograms every 6 to 12 months, and referring patients to a healthcare provider with cardio-oncology expertise if there's any concern about any abnormalities. And just high level highlighting a few studies that have looked at prevention, looking at whether we could start beta blocker therapy or ACE inhibitor or ARB therapies to try to prevent cardiotoxicity. Some studies have shown positive results with this, for example, with beta blocker and candesartan. Others have not shown much of a change, and there's still more ongoing trials. Really, this is we've barely scratched the surface with regards to looking at the cardiovascular side effects of cancer treatment and trying to prevent cardiotoxicity. This one particular study, the PREVENT trial from Wake Forest, we have participated in that as well, and that's an ongoing trial as well. And there's several other ongoing trials looking at cardioprotection during treatment. And so they've utilized statin therapies for their pleiotropic benefits, anti-inflammatory roles, and as well as beta blockers and ACE inhibitors for now. Entresto is also ongoing in this PRADA-2 trial, which has really good data from the heart failure literature, and this trial is looking at utilizing Entresto for cardioprotection in these cancer patients. So this is all ongoing trials right now. So final thoughts, really, there's a lot of overlap in the risk factors for cardiovascular disease and cancer pathogenesis. Cancer survivorship continues to increase because of the excellent work of our oncology colleagues, and that is creating a larger aging patient population that already have heart disease or risk factors for heart disease that are at a higher risk for cardiac complications down the road. Also recognizing that various chemotherapeutic agents, even the targeted ones, do have various cardiovascular side effects. There is more and more data showing that if we optimize the cardiovascular risk profile of cancer patients by aggressively controlling blood pressure, cholesterol, managing their diabetes, lifestyle modification with smoking cessation, diet, and exercise, as Dr. Franey will highlight in a little bit, we could potentially reduce the likelihood for treatment-related toxicities. And again, do utilize the cardio-oncology clinic, not just for treatment, meaning when patients end up with cardiac complications, but we are readily available to evaluate the patients for before treatment if they are going to be exposed to potentially cardiotoxic agents, and also those cancer survivors that would be in a higher risk category. And this is our cardio-oncology team. We also have Megan Weller, our physician assistant. Dr. Franey will talk shortly, and our nursing team. Thank you for your time, and I'll turn it over to Dr. Franey.
Thank you. Thank you, Wissam, and thanks for having us here this afternoon. I'm just going to share my screen here quickly. All right. Everyone can see and hear me okay? All right. So I'm going to be giving a brief talk on the benefits of exercise and how we focus on exercise therapy within the cardio-oncology clinic. And every time I put together this talk, I just remind myself I need to practice what I'm preaching here, because I think you'll see that evidence for benefits of exercise both in cancer patients and heart patients is pretty remarkable. So we'll start by talking about exercise during cancer treatment, exercise for the prevention of some of the cardiotoxicities that Dr. Abdallah just mentioned, exercise in cancer survivors, and what we would consider as a prescription for exercise. So we all know cancer and cardiovascular disease remain the 2 leading causes of death in Western society. This has been unchanged for some time. But I think one of the interesting things is these conditions are often thought of as two completely separate and different entities. And some cardiovascular disease prognoses is actually worse than cancer prognosis, although I think in terms of the general public, the perception may actually be the opposite of that. So also, as Wissam kind of focused on, there are shared risk factors between the development of heart disease and cancer. Things like hypertension, diabetes, smoking, sedentary lifestyle, these are all overlapping risk factors. We know that patients that develop cancer may have a more sedentary lifestyle due to treatment from their cancer or simply not feeling well. And additionally, this sedentary lifestyle may increase the risk for some of those cardiotoxicities that were just discussed here. So we all know that exercise is good for the heart. How can exercise benefit our cancer patients? And I think it goes to say that with the shared overlap of risk factors, we can come up with shared preventative treatment strategies for these patients. And really, we're going to focus on lifestyle changes and regular exercise here. So regular exercise, not just for cardiac protection and long-term heart health. There's a lot of statistics that I'll bring up in this talk, really just to emphasize the point of how beneficial regular exercise can be. Lots of studies have shown that being physically active reduces the incidence, the diagnosis of cancer by almost half. Also, after a diagnosis of cancer, regular exercise reduces the mortality by about 30%. Regular exercise also reduces the incidence of cardiotoxicity directly related to some of those cancer therapies, not just chemotherapy, which we'll get into in a little bit. So as you would expect, and as I mentioned, cancer patients are often more physically inactive due to a variety of different reasons. And yet exercise remains crucial for our cancer patients who are receiving different types of therapy. A sedentary lifestyle is essentially the perfect environment for tumor growth. It creates increased inflammatory response systems in the body. It increases oxygen-free radical production. All of these can promote cancer progression. So really crucial to emphasize this for our cancer patients. The benefits of exercise are really multifaceted. Regular exercise can increase the immune response, increase white blood cell mobilization. The increased immune response can help prevent cancer progression. The increased antioxidant enzymes that regular exercise produces can allow more rapid cellular repair mechanisms. And an increase in various proteins, including the VEGF proteins that were just mentioned earlier, can be cardioprotective and also inhibit tumor growth. So how much exercise do we need? There was a large study of over 50,000 patients that had a diagnosis of either breast or colon cancer. And these patients were looked at in terms of how much they exercised. They found that patients that exercised less than a half an hour a day, about 20 minutes a day, had a reduced mortality risk of about 24 to 28% compared to their sedentary counterparts. And this was regardless of the type of treatment they were receiving. If this was observational treatment, chemotherapy, radiation therapy, regardless of the treatment, these patients had better mortality outcomes. Some type of exercise is better than nothing, and I think this is what we really need to emphasize to patients undergoing cancer therapy. Anything that they can do, and I'll talk about various different exercise regimens at the end, is going to be better for both their cancer outcomes and their long-term heart health. Many studies have shown that patients who are able to remain physically active to some degree have more energy, less fatigue, they have less side effects related to their cancer therapy, improved pain control, and then certainly improved cancer outcomes. So let's focus a little bit on exercise in the prevention of cardiotoxicity. So as Dr. Abdallah mentioned, cardiotoxicity from our standpoint refers to damage to the heart caused by various cancer treatments. This does not just include decreased heart function or cardiomyopathies related to different chemotherapies. This can include different rhythm disorders, myocarditis, chest pain type syndromes. And the goal in prevention is to promote exercise to prevent cardiac damage to these patients during whatever type of cancer therapy they may be receiving. So there's a word that we can typically use called prehabilitation, and this is essentially preparing the body to tolerate a stressful event. This has been used by our orthopedic colleagues for several years. You know, patients that are preparing to undergo orthopedic surgery, knee or hip replacements, they often undergo physical therapy before the surgery. So utilizing this with our cardio-oncology program, we want to promote physical activity prior to initiation of certain chemotherapies to protect that heart function during the cancer treatment. There was one study that I think was really remarkable in terms of how much exercise could be beneficial during therapy. This was a relative small study, breast cancer patients that were undergoing anthracycline-inclusive chemotherapy, and they were randomized to either regular exercise, 20 to 30 minutes a day versus usual care. And one of the things they looked at was something called a peak VO2, which is basically how much oxygen or maximum oxygen consumption during exercise. And in the cardiology world, we use this as a marker of overall cardiovascular fitness and kind of prognostic implications too. And what this study found was that in the patients that did not regularly exercise, they had a 15% reduction in that peak VO2, which essentially is equivalent to 15 years of aging, just within a 4-month period of chemotherapy. The patients that were able to exercise regularly certainly had better outcomes with a decreased or improvement in their peak VO2 with their cancer therapy. So I thought that was quite striking. Another thing that we focus on that exercise can certainly help with is maintaining a healthy body mass index. So body mass index essentially refers to the patient's weight divided by the square of their height, normal being between 18 and 24. One study looked at patients that were undergoing treatment for non-metastatic breast cancer and kind of looked at them in terms of their BMI being underweight, healthy, overweight, or obese. And I think this is pretty intuitive, but certainly patients that were overweight or obese had significantly increased cardiovascular risk factor prevalence. So they had more high blood pressure, more high cholesterol. But one of the more interesting things is patients that had higher BMIs were more likely to develop cardiotoxicity. In fact, being obese was associated with a 3-fold increase of cardiotoxicity, regardless of the type of therapy that these patients were receiving. So this is just BMI alone, and I think that certainly promoting regular exercise to maintain a healthy BMI during therapy can be very beneficial for these patients. Also, as Dr. Abdallah focused on, the good news is that cancer survivorship is increasing. And I think this is a patient population that we need to continue to follow and continue to promote regular exercise, as you'll see soon here. This chart just shows that by the year 2040, there's a projected 26 million cancer survivors, and this is divided according to age group. And we know that as our cancer survivor age is increasing, we start to see increased incidence of cardiovascular disease in these patients. So in terms of cancer survivor, cardiovascular disease may become the leading cause of death besides breast cancer at about the 10-year mark. You kind of see this overlap here. So this was, again, a large study of breast cancer patients, breast cancer survivors, and about the 10-year mark, heart disease became the leading cause of death, and breast cancer deaths started to decline. So as we see more survivorship, we're certainly going to see more heart disease in this patient population. In terms of cancer survivors and exercise, again, this is another study. The goal was to evaluate the association of regular physical activity and the development of heart disease. Again, we saw a large reduction in cardiovascular disease approaching 35% in breast cancer survivors that were able to maintain moderate to high intensity levels of regular exercise. The reduction in cardiovascular risk was also identified in survivors reporting lower levels of exercise. So again, it's going to show that some degree of physical activity, whatever can be maintained, is certainly better than no physical activity at all. This chart was taken from the Women's Health Initiative, where patients were kind of divided into how much exercise they were able to do. We quantified this by using an exercise equivalent called MET, metabolic capacity, in these patients. And you can see here that in terms of patients who exercised a high degree, greater than 18 METs, they certainly had a decreased risk of cardiovascular events. But again, the point of this is to show that any degree of exercise can be beneficial in cancer survivors. So I think we've kind of harped on the point that exercise is beneficial both in heart disease patients and cancer patients. It can decrease the risk of secondary cancers, decrease the risk of recurrent cancers, improve your risk for cardiovascular disease, and improve symptoms associated with some of these conditions as well. So what should we tell patients who may be undergoing therapy? What should their goals be? Certainly want to maintain good physical function, good social function as much as possible. These treatment plans are often optimized per the individual, per the age, per what their baseline physical abilities may include. We want to reduce the symptoms associated with their therapy and maintain that optimal weight, as we talked about the body mass index a little bit earlier. So when we talk about exercise with patients, there's really two types. There's resistance training and aerobic training. Resistance training is often a little bit easier to maintain for patients that may be undergoing chemotherapy. It doesn't require too much talking or strenuous physical activity, but it certainly can improve outcomes. This would be kind of using resistant bands, stretching types of exercises. These types of activities have been able to be maintained long-term in patients that are undergoing chemotherapy. Aerobic training, if the patient's able to do that, can also be very beneficial. Aerobic training can be divided into mild intensity, moderate intensity, and vigorous intensity. I tell my heart patients that if they really want to get a good cardiovascular workup, they should not just be strolling during their walk, but it really should be a little bit difficult for them to maintain a regular conversation. That's kind of how you know that you're pushing yourself to that moderate intensity degree there. In terms of how much do we need, the American Heart Association recommends at least 150 minutes of that moderate intensity physical activity most days per week. So the easy way to remember it is 30 minutes a day, 5 days a week. If you want to decrease the time that you do exercise, you can also increase your physical activity to that vigorous level, and then you only need 75 minutes a day. But whether you're aiming for the 150 minutes of moderate activity or 75 minutes of vigorous activity, the time can be divided. It does not have to be consecutive, 15 minutes in the morning, 15 minutes in the afternoon. It all is beneficial in terms of long-term heart health. So final thoughts, I think that we've shown exercise can be an effective treatment for cancer patients prior to chemotherapy, during chemotherapy, and certainly for that survivor population, not just for long-term cancer outcomes, but also for cardiovascular survival. Exercise can counteract the negative effects of certain cancer therapies. So chemotherapy, radiation therapy can even be beneficial in terms of surgical therapies for cancer patients. And it should be tailored to the patient on an individual basis based on what their level of function is, just reiterating the fact that some level of physical activity is certainly better than no physical activity in terms of their long-term survival. And that is what I have for you this afternoon. So thank you for your attention, and we're happy to take any questions.
Thank you very much, both Laura and Wissam, for this elegant presentations. I'll start the questions myself for either one of you. Would you just comment on what will be the ultimate goal of the time of evaluation, the length of evaluation, the duration of the care under your care for oncology patients? Because most people think that, oh, when they have symptoms, let me send them to cardio-oncology clinic.
Right. you want to go ahead, Laura?
Sure, go for it.
Well, I think it's going to depend on what kind of treatment and what they've been exposed to. So, for example, in patients, if they've been receiving only anthracycline-based chemotherapy, the guidelines will say to get that repeat echocardiogram at the conclusion of the anthracycline-based chemotherapy and then 6 months afterwards. And then it's really going to be very much patient specific. So depending on their risk factors or if they have coronary artery disease, and sometimes we'll be looking at a staging CT, patients who never had any known coronary disease, and we find coronary artery calcification. Well, then they have heart disease. So then they become our patients pretty much forever after that. And so for other patients who have had radiation exposure, the guidelines will say to evaluate these patients clinically once a year and to get an echo on them once every 5 years. And that's indefinite as well. Other patients, let's say if they've been exposed, for example, only to HER2 blocking agents, where we know most of the time that's reversible and shouldn't have any cardiotoxicity after the conclusion of treatment, then those patients, we might not follow them long term. Or patients, we've had young patients, let's say, who've had colon cancer and they've had vasospasm while on treatment with 5-FU, and we've been able to put them on vasodilators or nitroglycerin, long-acting nitroglycerin, and manage them during that time they are on 5-FU treatment. And when they're done with that, those patients, we might not need to see them again if they don't have any other reason for us to follow up with them. So I think it's all going to depend on what kind of treatment and on each patient, what their risk factors, what their underlying comorbidities are, and what cardiovascular disease do they already have or not.
Thank you. My question, just to follow up, most oncologists honestly are not aware of these variables. You guys do it, of course, 1,000 times better. So how we can share this knowledge, because as I told you, most people may not really give the time to do this detailed assessment that you and Laura and people in this field, you know, you immediately check the boxes and you say, okay, this is the plan. Is there an opportunity, my question, to develop a form that can be embedded, let's say, with the patient initial visit, initial evaluations?
Yeah, I mean, I think that that would be an excellent opportunity, and it could be quite simple from both a patient and a physician perspective. I mean, really, we would want to know kind of the main cardiac risk factors. If they've had those risk factors, we'd want to know if they have any heart disease, if they've had any chest imaging demonstrating coronary artery disease, and certainly if they're having any symptoms. So I think that could be a quick form that would be useful for both patients and physicians.
And Dr. AJ, I know there's an initiative to establish these clinical care pathways. And so if there's anything we can help with to dovetail into that, at which point in the clinical evaluation and algorithm when cardio-oncology services should be considered, I think that will be an excellent opportunity for us to be incorporated into that. The oncologists are already so busy managing the acute condition at the time. These things sometimes do fall to the side, but certainly, with trying to create more awareness and outreach about this, we hope to find these patients. But if there is a means within the system to flag these patients, or so-and-so has these, risk factors, and you are starting this kind of treatment, consider cardio-oncology referral or whatnot, that would be something amazing to set up. Absolutely.
I love the idea. Actually, that will be a great project for partnership. So I will follow actually with you and Laura, and of course Penny and Nancy and Mary Kay probably on the line. This is a great actually topic. We'll invite you for our CPC actually.
Sure, absolutely, yeah.
Council. Okay.
With the clinical care pathways, yeah, absolutely.
Yep. Thank you.
Great. Encourage anybody that has a question to either raise your virtual hand or put the question in a chat. There is a question in a chat right now. At what point should patients receive a referral to your service?
Sam, do you want that
Go
one?
ahead, Laura.
Okay, so I think this can be pretty complicated in terms of what's going on, but in general, if the patient is undergoing any cancer therapy that has potential for cardiotoxicity, ideally we like to see these patients before the therapy has been initiated, because we can really focus on optimizing cardiovascular risk factors, talking about exercise regimens, educating about what symptoms to look for. So ideally, we would like to see patients that are starting cancer treatment before they start receiving therapy. I don't know, anything else, Wissam?
Yeah, and sometimes we'll make changes to the current regimens. For example, we've seen patients who have hypertension, and let's say they're on a calcium channel blocker, and their hypertension is actually under control. But there is data showing that with ACE inhibitors and beta blockers, those are cardioprotective, but those are also antihypertensive medications. So we've made changes to those regimens. We would stop their calcium channel blocker, put them on an ACE or ARB or beta blocker, because that has also cardioprotective benefits in addition to treating the hypertension. So it's kind of 2 for 1. So even though they're asymptomatic and their blood pressure is under control, there are some things that we could still do to focus more on the prevention aspect of things, as Laura highlighted up front.
Okay. Any remaining questions for Dr. Abdallah? Dr. Abdallah or Franey? All right, well, thank you so much for that great presentation. We really appreciate your support of all of our programs and for taking part in the symposium today with us. Thank you very much.
Thank you for having us.
Thank you.
Thank
All
you.
right, we're going to take a brief break. If we could come back together at 1 p.m. We have Dr. Steensma, who will be presenting on the Benign Tumor Clinic. And so please take a break, drink some water, stretch it out, get a healthy snack, check your CME account and attendance. And there is a link in the chat for more inspiration and information from HealthBeat. See you all soon. Okay, thank you everybody for joining that first session. And if you're just joining us, looking forward to a great topic coming up next. We're going to hear from Dr. Matt Steensma, and I'll give his bio here shortly. But before we begin, if you're just joining us and claiming CME credit, please sign in with the Survey Gizmo link that is in the chat. If you don't see the chat section, select the chat icon on your toolbar to view the thread. Please mute your microphone and turn off your video. And to pin the guest presenter, Dr. Steensma, right-click on his name and the icon down below, and you can see him there. He's showing his video, and select the pin option. All right, and Dr. Steensma is going to be our last and final presenter of what's been a really interesting week this week. So thank you for joining us, Dr. Steensma. Dr. Matthew Steensma is a graduate of the Musculoskeletal Surgical Oncology Fellowship at Memorial Sloan Kettering Cancer Center in New York, New York. Dr. Steensma is a surgeon scientist with an interest in sarcoma biology and has faculty appointments with Van Andel Research Institute and Michigan State University School of Medicine. He is a graduate of Hope College in Holland and received his medical degree from Wayne State University School of Medicine in Detroit. He completed his internship and residency in orthopedic surgery in Grand Rapids in the Grand Rapids Medical Education Partners Training Program. The scope of Dr. Steensma's practice includes the surgical treatment of primary and metastatic tumors of the musculoskeletal systems. This includes both benign and malignant conditions of bone, soft tissue, and nerve, as well as extremity and pelvis lesions. In conjunction with Helen DeVos Children's Hospital and the Spectrum Health Regional Cancer Center at Lemon-Holton Cancer Pavilion, Dr. Steensma provides care for children and adults afflicted with musculoskeletal tumors. And Dr. Steensma, I will turn it over to you for your talk on benign tumors. Thank you.
All right, thanks, Alyssa. Can someone just confirm that they can hear me okay?
You're a little bit muffled.
Okay. I'm going to get close to the microphone here.
There you go.
That good.
Yep.
All right, well, good afternoon. It's officially afternoon because it's after 1 o'clock. I have a somewhat brief presentation on a benign tumor topic that's near and dear to my heart. I think many times we associate regional cancer centers with all cancer care because the task is very large and it's critical care for our community. But there's this other aspect of cancer care that really falls into the diagnostic realm. We often get referrals of patients that may have cancer, could possibly have cancer, and need to sort it out. And in orthopedic oncology, this is a critical aspect of caring for patients with sarcomas. But in our community in particular, there seems to be a lot of benign tumors and not a clear pathway for this care. So to give you a sense of our background, orthopedic oncology services have been here for 10 years, over 10 years. And we see just about over 80 adult sarcomas per year. That includes bone, soft tissue sarcomas, retroperitoneal sarcomas. The pediatric population is separate from these numbers. And in general, there are not a lot of pediatric sarcomas. But if you start adding up all the sarcomas, pediatric and adults, the health system probably sees close to 100 sarcomas a year, which puts it into a moderate to high volume, as a moderate to high volume center. As many of you know, sarcoma is a multidisciplinary team-based care model. It includes orthopedic oncology and radiation oncology, medical oncology, and surgical oncology. Much of the diagnostic work is done by the surgeons or coordinated by the surgeons at least, so we're often the point of first referral. Benign tumors come to us frequently, and many times we have to turn away patients with benign tumors because we don't have the bandwidth to manage them on top of the kind of hugely complex cancer population. But what often happens in the musculoskeletal system, if someone has a benign tumor, there's often a lump or a bump present. And like many presentations, if there's any cancer concern, usually the patients are somewhat anxious about this. And so they often seek out care through their primary care physician as the first line of kind of workup. And in general, benign tumors are not difficult to work up to try to understand what to do, but there are definitely some pitfalls. And physical examination is a really good place to start for these. It's really good to estimate size and it can help narrow the differential diagnosis. But in general, physical examination is non-specific. So just because it's soft doesn't mean it's a lipoma. It could be a lipoma or fatty tumor, but the physical examination really doesn't tell you that for sure. History, which is really interesting, is really unreliable. And starting in medical school, we teach it that history and physical examination are the most important aspects of patient care. But when it comes to benign tumors and musculoskeletal extremities, history can actually be very distracting, where there are definitely cancers that will lie dormant and not grow in size for many years. And then there are benign tumors that grow really fast. So common sense suggests if it's growing fast, it's malignant, but that's not always the case. Common sense suggests that if it's not growing, it's not cancer. That is definitely not the case. Sarcoma can lie dormant for a long time, particularly certain subtypes like synovial sarcomas. I have an interesting patient story to relate. I had a patient who presented to me with a mass on her thigh about the size of a golf ball. And she brought in a picture of herself from a family reunion 20 years prior, and she held it up to her leg, and she's like, I'm confident this hasn't changed in size. And I agreed, it didn't look like it at all. And she ended up having, after all the workup, a high-grade synovial sarcoma. And by every piece of evidence we had, this sarcoma had been there for a couple decades. And she was cured of this sarcoma. So sarcomas are the great pretenders. They often fool even the most seasoned physicians. They even fool us from time to time with all our advanced training in this disease. When I trained, even 15 years ago, ultrasound imaging was still somewhat rudimentary for musculoskeletal tumors. Now, with the advances in technology, ultrasound is really being utilized more, and the pictures are much better. We have some specificity as the tumor makeup. The echogenicity can tell us whether it's made out of fat. The Doppler flow analysis can give us a hint about the blood supply. Is it rim in hand? Is there a rim-based blood supply or peripheral blood supply, or is it central in the tumor? Is it cystic? And then ultrasound is a very precise way to monitor size, even if you're observing a tumor, to see if size has changed over time. The old rule of thumb was that anything bigger than a golf ball size mass deserved an MRI with and without contrast. Now that ultrasound has improved, I think a lot of people are questioning whether an MRI is even needed for a golf ball size mass, and perhaps 5 centimeters is a better threshold for using MRI. Our caseload, about a third of our caseload in orthopedic oncology are diagnostic cases, which are effectively rule-outs, where either the referring physician has concern for cancer or the radiologist has raised concern for cancer, the differential, and patients are sent to us to sort this out. A lot of these patients are driven by coincidental findings where they get in a car accident and have a CAT scan, and lo and behold, there's a spot in their pelvis, or an ankle sprain and there's a spot in the bone. Sometimes the lumps and bumps are at sites of prior trauma. Many people come to the cancer building to see the orthopedic oncologist very nervous because even though they really don't have cancer, they have to come here to rule it out. In this population in West Michigan, there are a significant number of families that have inherited tumor predisposition disorders. For musculoskeletal system, one of the more common ones is a condition called familial lipomatosis. And many of these patients will have multiple lipomas that grow. They can present looking aggressive, but they're generally fatty tumors that are benign. But a small percentage will develop sarcomas from these fatty tumors. So this is a population that we actively manage. And then there are just the random lumps and bumps that happen over the course of many decades, where some of them can be vascular tumors, nerve tumors, skin-based lesions. But because it's a lump and a bump and it's raising concern, patients come to their doctors for care. What we've observed over the last decade is that there really is no unified care pathway for these patients. I think just in talking to the primary care department here, leadership, and some of the physicians, women's health leaders, my wife's an obstetrician, I get to pick her brain about these ideas. There really isn't an intuitive place to send a patient like this where you can effectively manage them So patients are often sent to dermatology, general surgery, sometimes orthopedic oncology, surgical oncology, primary care, and all these patients are managed differently. And what we see by the time patients reach us is that patients often have a lot of unnecessary testing. There's an overutilization of advanced imaging tests like MRI, CAT scans, when an ultrasound or frankly just observation could have sufficed. And patients are concerned by the time they get to us. The communication is often difficult because the referring physicians don't have a lot of expertise and they can't give good explanations for what's happening. And then there's also some of these diagnostic transitions where, 30, 40 years ago, what was called cancer is no longer a malignancy, it's considered a malignancy. And this is, again, very true of the fatty tumors. Well-differentiated liposarcoma was the term given to large fatty tumors in the extremities about 30 years ago. And the World Health Organization declassified or pulled this out of the cancer category and put it in an intermediate category called atypical lipomatous tumor, or ALT. Sorry, I misspelled that there. There are still radiologists and pathologists who use the term sarcoma for these cases, and patients get unnecessary treatment. They get very morbid, wide resections for these tumors. And even in the last year, we've had a couple radiation oncologists call us saying, how would you like us to irradiate this completely benign tumor? And so it's a very tough task to take something that was cancer and educate an entire population of physicians on how to treat it as a benign entity. So we often see patients very angry at referring physicians because they were told they had cancer and then they find out they didn't, or vice versa. And so there's this medical legal risk aspect to lumps and bumps that's sort of in the background of most of these cases. Also in the background is what we know as sarcoma specialists is this pitfall in diagnosing sarcoma. There's some really good literature on this that extends back to the mid-'80s, and that is that if a sarcoma is not managed appropriately from the beginning, there's a significant risk of patients undergoing unnecessary amputations and for undergoing worse oncologic outcomes if they're not managed by a specialist. And it seems very heavy-handed. It seems like a very aggressive capture model, but sarcoma is tricky enough that if you don't have extensive training in it, it's very likely you'll make a mistake in management. So there were several education interventions proposed by the Musculoskeletal Tumor Society. Some of them lasted 10 years, and they were unable to make a change in the rate of inappropriately excised sarcomas. One of the most common things we see is a sarcoma that gets referred to us as a lipoma based on a presumptive diagnosis on physical exam. And each year we see more than 20 cases of what we call inappropriately excised sarcomas. And these cases are referred from many different directions: general surgery, ortho, plastics, primary care, derm, and even surgical oncology at times. And in most of these cases, there's even preoperative imaging that raises concern for sarcoma. So it's unclear what the decision-making process was leading up to an inappropriate excision. So an inappropriate excision is really defined as a less than wide resection of a sarcoma, meaning you leave significant disease burden behind and contaminate the area where the sarcoma is present originally. Sarcoma is one of the most implantable cancers known to man, so it doesn't take much to stimulate a recurrence, or it doesn't take much for a hematoma to spread it regionally when it could have been managed in the local site of disease. So if the data supports the idea that if someone undergoes an inappropriate excision, that there's an increased rate of local recurrence, there's decreased survival, particularly for the larger sarcomas, definitely increased surgical morbidity, including amputation. And radiation oncology often has to extend fields to capture areas of hematoma or contamination. And these are some of the most difficult conversations we have with patients. And it's not uncommon for people to be angry enough that they threaten to sue the referring physician. What's very difficult about these situations is that most of these inappropriate excisions are completely avoidable if there's proper assessment and surgical technique. So the Benign Tumor Clinic that was launched a couple of weeks ago, actually, is a response to a number of issues we see. I think the most burgeoning aspect is to try to identify sarcomas before they're inappropriately excised. But granted, we'd have to treat a lot of patients to find the, a few sarcomas that we're trying to capture every year. But in our minds, because of all the damage it does, it's worth doing this. But there are many, many good reasons to manage benign tumors in a specialty clinic because there's a significant cost of care related to overutilization of advanced imaging tests and overutilization of surgery. And based on our research, we estimate there's more than 1,000 patients per year at Spectrum Health that are evaluated for benign musculoskeletal tumors. It also gives us an opportunity to develop more effective collaborations with referring physicians. Many primary care doctors are comfortable monitoring as long as they know what tests to order and how often. And so part of the benign tumor clinic is working with the referring physicians if they want to manage the care. And then also working with our surgical specialists to give advice about how to excise or how to manage lumps and bumps. Another critical aspect of this is to try to establish a basis or an opinion that justifies non-operative care. There are a lot of benign tumors that do not need surgery, but patients end up forcing the surgeon's hand into surgery in many ways. They try to persuade the surgeon to take it out because they're nervous and they just weren't properly educated about the risks of observation. And most fatty tumors, which are not growing, they don't have to be removed. And when you start going through the risk-benefits rationale of surgery, many patients are very comfortable at that point, if properly educated, not to remove them. And the other aspect is when resection is needed, right now, most, if not all, except for our practice, most of these tumors are being removed in an inpatient setting, which is a very, very expensive and costly way to remove a very benign sort of outpatient type surgery. And now with virtual health being at our fingertips and very accessible, this is a conversation that we feel very comfortable having on a computer. The management of a benign tumor can certainly be done virtually, and because the Regional Cancer Center has a significant draw, even outside the 17-county area, we anticipate that this will be a very good opportunity to have a virtual health model around one particular condition, even outside of our community. So these are the reasons we launched Benign Tumor Clinic. If you're wondering how it all works, basically the BTC clinic is an APP-led, physician-overseen clinic. And for those of you who know Stacy and Annie, our PAs, they're extremely talented, skilled PAs, very good with patients. They will be doing the initial intake and pre-referral management on these patients. And effectively what happens is once you refer these patients to our office, they will be triaged into a BTC clinic route. So if we see on the referral form, or if we get a phone call saying this appears to be a benign lump and bump, what will happen is that these patients will be contacted. Before they're even seen in person, we'll get an assessment of their history, an assessment of their imaging, and basically set up an appointment where everything is in place that if they are requiring resection of the mass, that it can be done in the office. Now, most of these patients are going to be deemed low risk, and if the ultrasound does not show blood flow and it's clearly echogenic like adipose tissue, we will counsel them towards observation, which either we do or we work with the primary care referring physician to accomplish. If there are any suspicious findings like aggressive growth pattern or concerning ultrasound findings, or if they have a family history of a condition like lipomatosis, those in their large masses, these patients will be inserted into the orthopedic oncology standard workflow and triaged as such. Ultrasound ends up being a very effective screening tool for us, and ultrasound imaging, as you know, can be done on the inpatient side in the radiology department. There's definitely an increased use of outpatient ultrasound techniques. So ultrasound is an available, cost-effective imaging tool for us. So if you have a lump or bump, or you know a patient who has a lump or bump, what we're asking is that you refer to the Spectrum Health Orthopedic Oncology Clinic, either Dr. Peters or myself. You can put either one of our names on it. And the nature of the referral would either be BTC, benign tumor, or you can just include the details of the presentation and we'll figure it out for you. And our office phone number is below. So that's all I have. Does anybody have any questions?
Feel free to raise your hand, or if you'd like to type a question into the chat.
Thank you very much, Matt, for outstanding presentation as usual. I will start just a quick question for you. Just for these tumors, like how you are going to communicate that to collaborating physician as benign tumor? You know, I'm just a little bit concerned about people may not be understanding the purpose of your lumps and bumps clinic.
Yeah, so a lot of times when patients have a mass on their extremities or their leg, it's often something they've had for many years. It's often something that doesn't hurt, but they're just not sure about it. And so they raise attention to their primary care doc, and so that if the primary care physician is uncomfortable managing that aspect, that's the point at which they would refer to us. Now, sometimes when we see the documentation, we can look at it and realize that, yes, it's a small fatty tumor. It doesn't require resection. And we would communicate back with a primary physician and say, you know, we're happy to see this patient and counsel them. If you want to do the monitoring, this is what we would recommend. If you would like us to do it, that's fine too. You know, certainly if it's something that's growing and there's a lot more concern than sort of the average patient with a lump or bump, then that would be just the same destination for the referral, but include the comments about the, you know, enlarging mass.
Excellent. Just one more follow-up question. In your research on what you do, is there any genomic actually markers being studied for benign, or to differentiate at least borderline lesions when you get some path that is ambiguous or not clear?
Yes, so the molecular diagnostics are worked out, and the Spectrum Molecular Diagnostics Lab has the tests in place. There's a gene called MDM2, murine double minute 2, which is amplified in atypical lipomatous tumors, and it is typically not amplified in benign lipomas. So when we resect a mass, particularly the masses that are larger than a golf ball, this test is often used to determine whether it sits in the intermediate category or if it's benign. If it's an intermediate category fatty tumor, that patient requires more diligent surveillance and a longer surveillance period, which we would perform. It's a test that also has an antibody. There's an immunohistochemistry test that's accurate. And there are a number of pathologists here who are excellent morphologists who will call ALTs or benign lesions just based on the shape and cells of the tumor.
Thank you.
Great. We have another question in the chat. Do you see adult and pediatric patients?
Yeah, good question. Orthopedic oncologists are trained to care for both adults and children. So there's really no age group that we won't see. And for that reason, we often sit in this unique AYA, or adolescent young adult care niche, where many patients, when they turn 18, they can't see their pediatric cancer provider or pediatric surgeon. So we often assume care kind of in the late teens, early 20s of patients who have had cancer or lumps and bumps. But yeah, there's really no age group where we won't see a patient.
Great. There's another question in the chat. You mentioned overutilization with imaging. What imaging would you like to see for the benign tumor clinic prior to referral?
Yeah, great question. It's a pretty simple answer. We would rather see no imaging at the point of referral. And if you really do feel compelled to get an imaging test, is to get a diagnostic ultrasound. The diagnostic ultrasound technique that's used by the musculoskeletal radiologist at Spectrum Health is obviously a different process than what I would use if I had an ultrasound machine in my office. So the highest quality read and interpretation is utilizing the Spectrum Health radiology services. But if you have ultrasound and you have training and you have comfort level and you can comment on echogenicity, Doppler flow, size, then yeah, doing ultrasound yourself in your office is very useful too. We strongly suggest not getting an MRI on a patient that has a mass that's golf ball sized or smaller. There really is no basis or use for that MRI, and it definitely represents some waste.
Okay. I have another question here, which is, will you be offering in-office and same-day procedures?
Yes, so for small masses, these masses are things that can be removed in the office, and we have an in-office procedure workflow that we'll utilize, and patients will be counseled about this before they show up. There are other types of masses that are like nerve tumors are really too painful to remove in the office, or vascular tumors, they can bleed too much to remove in the office. So if the ultrasound is showing one of those types of tumors, we would tell patients, you know, look, it's unlikely that you'll have same-day surgery because of these issues. So yes, they will be offered. No, not in all cases, only when feasible.
Okay, thank you. There's another question in the chat. Can you expound on management of non-operative care?
Yeah, so non-operative care is probably our best tool in the toolbox. So the natural history of most benign lumps and bumps is growth, but not unchecked growth. So many of them grow to a certain size and then stop. And for some reason, patients are often referred where that growth is in the plateau phase. So what we like to do is once the patient is referred, or once we hear about the case, we get an initial size assessment. If we determine that it's low risk and that there's not a concerning history for rapid growth, we usually do an interval scan. So ideally, it's ultrasound to ultrasound, and it can be anywhere from 3 to 6 months, just depending on the patient, their preference, and sort of the presentation. Ultrasound is very robust for dependent observations, meaning you're not going to get a wildly different measurement, even if another operator does the measurement. And the technique, especially for a superficial lesion, tends to be really good. The other aspect is that there are some patients who are not healthy and they get a mass and the physicians aren't quite sure what to do with it. And so they said, well, we better just get it out to make sure it's not cancer. And so they submit a patient with comorbidities or risk to a procedure where complications occur. Truthfully, in many, many cases, you can get the confidence level you need to not operate on these. And there are definitely some patients with histories of blood clots or heart attacks or advanced COPD, baseline O2 requirements, where really removing a lipoma just is not advisable. It's not a good idea. Hopefully that answers your question.
Great. Seeing as you're starting up this clinic, and this is kind of a mixed audience, you know, we have some oncology, some primary care, leadership, clinical staff. Can you think of anything that this group could do in particular to help promote this clinic?
Yes, I'm glad you asked. So trying to make the physician community aware of health services is challenging. And, you know, we've been here for 11 years, and there are many, many physicians in this community that really don't know what orthopedic oncology is for or what it does, despite a lot of educational effort and developing good relationships with our referring base. So we will be sending out some email reminders about the clinic, and I'm trying to get into some management council meetings just to raise awareness of it. But word of mouth is sort of king in this community. So if you can pass this information along to your physicians, to the nursing staff, the people that manage your referrals, I think that's probably the easiest way to help. I think too, being aggressive with referring these patients helps, because the patients themselves will talk, and we've definitely seen that in orthopedic oncology, where a lot of times a patient had a good experience and they told their friend, and then a week later they had a similar problem. I don't think we have the marketing budget to put out a billboard or have a massive flyer campaign. So yeah, we're definitely relying on all of you to spread the word.
Great. I just added a comment to the chat. We do have a few extra minutes. If anybody has any questions, maybe even outside of the benign tumor clinic that you might have for Dr. Steensma, feel free to raise those. Give it the requisite 10 seconds, right? The virtual 10 seconds for people to get off of mute and ask the questions. Great. Well, this has been wonderful. Thank you so much for taking your time to present Dr. Steensma today. We look forward to seeing how this clinic goes into the coming months. And thank you all for joining the symposium today. This is a wonderful week. I hope you enjoyed the new format. I think we had a successful turnout, and it's very interesting that we were able to just keep things going virtually. So thank you so much for joining. I'm looking for my little tip sheet here a second to see if there's anything else that I am supposed to say. Catherine, feel free to jump in. I'm sorry, I lost my sheet somehow. Thank you all. CME credit claiming, I think the link is available either in the meeting invite or in the chat, and have a wonderful weekend.
Thank you all.
Thank you.
Thank you all. This is Catherine Williams, and just want to jump in here quickly to say thank you to all of our hosts and presenters this week. It really has been a great experience, even though we have unfortunately not been able to be together and in person this year. Our first go at a virtual symposium has gone very well. As many of you know, a daily recap is sent out with links to recordings and our evaluation forms. For those of you who are claiming CME credit, that evaluation is required in order to get that credit. So please do complete that. But we also do appreciate your feedback. And so for anyone who is not claiming CME credit, we are providing the survey gizmo in the recap emails. So please be sure to complete that. I look at those every day, and I think they will definitely help to inform where we take this symposium next year. As we can anticipate, it may in some capacity be virtual again, but we hope it is more of a hybrid. So with that, I would also like to invite you to share in the chat or in your survey any topics that you as audience members are interested in us exploring for future symposiums or other educational programs and series. So thank you again. We appreciate you joining us this week and look forward to future opportunities to engage and learn from each other in this community.